All right, good morning, everybody. I hope everybody's having a nice day. Today, we're here to hear a very nice talk from Dr. Scott Roberts. He is a professor of health and behavior and health education at the University of Michigan School of Public Health. He is also our core leader for the Michigan Alzheimer's Disease Center. So without further ado, let's just give him a round of applause and you can come on up.
Well, thanks, Stephanie, and thanks everybody for coming out today, dealing with the joys of parking registration and such. Can everybody hear me okay? Great. Well, as Stephanie mentioned, I'm going to be talking about genetic testing for Alzheimer's today. And it's a topic that I think a lot of folks are interested, particularly people who've had a family history of Alzheimer's or another kind of dementia. So hopefully this will be useful information for you. And given that we're a relatively small group, I think we can make this interactive. I mean, I've got some slides I want to run through, but if you have questions, just raise your hand. We'll also have some time for Q&A at the end. And then afterwards, we also have time for you guys to check out. I'll be talking a little bit about what's going on at our center beyond genetic testing, in case you're interested. And then we've got Panera lunch to reward you for your attention. So as was mentioned, I'm a professor at the School of Public Health, and how I got interested in genetics, I'm not a geneticist by any stretch of the imagination. I'm actually a clinical psychologist, and I was working at Duke University in the 1990s when that was kind of the heyday for finding a lot of new genetic links to the disease. And so it raised a lot of interesting questions about, should we do genetic testing? What does it mean to give people information about their genetic risk for Alzheimer's, and how do people respond to learning about it? So that's kind of what my background is I do a lot of research focused on people's understanding of what genetic test results mean and how they react to those. So I'll tell a little bit about that when we get into it. But I just wanted to start just to make sure we're all on the same page here. Let's see, there we go. Basically, just to define what we mean by Alzheimer's and dementia, because a lot of people get confused by that. They're like, well, is dementia the same thing as Alzheimer's? Is it something different? And so just to let you know that dementia really is a broad, what we call umbrella term. So it's really describes what we call cognitive impairment. So kind of basically problems with memory or other areas of thinking that slowly get worse over time. And so basically dementia just describes that kind of set of symptoms. And really, it doesn't say anything about what is the underlying cause of the dementia. There's a lot of different underlying causes though, and those are the different types of dementia. So Alzheimer's happens to be the most common type of dementia in older age. And it's caused, you may have heard, by there's amyloid plaques and tau tangles. These are things that start to develop in the brain and cause people's memory and other thinking abilities to change. But there are other types of dementia as well that you may have heard about: vascular dementia, Lewy body, frontotemporal. And so these are all different underlying causes, but they all create what we call progressive decline in people's thinking abilities over time. So I'm going to be talking mostly about Alzheimer's today, since that's the most common type of dementia, and that's what we know the most about in terms of genetics. But I wanted to make sure that to recognize that there are other types of dementia as well out there. So any questions about that, definition? Yes, ma'am. Yeah, so Parkinson's, it's a great point. Parkinson's is a neurological condition that can have dementia. It doesn't always have dementia associated, but as it progresses, sometimes you can have the decline in memory and thinking that constituted dementia. So that's a great point. So it's not quite as common as some of these to have the dementia part, but it's a relatively common neurological condition overall. And it also involves some movement issues too, not just the cognitive challenges. Yeah, so this is not an exhaustive list of dementias. You can even have dementia in the context of HIV, for example. So there's many ways that people can have memory or thinking problems. I'm just kind of listing some of the most common types here. But great question. So when we talk about Alzheimer's, I'm going to talk a lot about genetics today and genetic risk for the disease. But I wanted to point out that it's what we call a complex condition. There's a lot of different factors that go in to elevating risk or maybe even protecting against risk for Alzheimer's. So you can see some of them listed here. The most prominent is age. So as we get older, get into our 70s, 80s, and 90s, the chances of Alzheimer's go up with age. And that's the most important risk factor, I think, of all. There's some other important risk factors to be aware of. Women are at slightly elevated risk for Alzheimer's compared to men. If you've had a family history of Alzheimer's, particularly if you have an affected parent or sibling, your chances are elevated. You still doesn't mean you're going to get Alzheimer's, but you have a higher chance. Like, so for example, to put it in numbers, the general population risk for Alzheimer's is about 10 to 15%. And if you have that affected parent or sibling, then your chances are about double, 25 or 30%. So still more likely than not that you'll never get Alzheimer's, but still you have a higher chance than the general population, if that makes sense. We'll talk about genetics, and head injury, as you might expect, is also a risk factor. But fortunately, there are some protective factors as well. And so higher level of education has been associated with lower chances of getting Alzheimer's. There's a slogan out there called what's good for the heart is good for the brain. So the good thing is we know that there are a lot of ways we can reduce our risk for heart disease, whether it's physical activity or managing hypertension, those kinds of things. But we're also finding out not only are those things good for reducing risk of heart disease, they're also good for reducing risk of Alzheimer's and other dementias. So that healthy lifestyle is really important to keep in mind. And then also social and cognitive engagement are protective as well. And so this old kind of adage of use it or lose it, I think is relevant when we think about social and cognitive engagement that keeps us stimulated. It might help us stay sharp for longer. And of course, a lot of these things are just good to do anyway for all kinds of other reasons. They're good for our mood. They're good for reducing risk of other conditions. And for a lot of us, I think it's just part of our quality of life is to remain, socially engaged and to be doing things that keep us interested and active. So that's just a quick tour of some of these risk and protective factors for Alzheimer's. Any questions? And again, this is not an exhaustive list either. I'm just highlighting some of the major factors involved. Yes, ma'am.
I have a friend who's had 2 head injuries. So does that increase the risk? And what percentage of people with head injury would you say end up with some sort of dementia?
I do, off the top of my head, I don't know in quantitative terms. A lot of this has to do with how serious was the injury, what part of the brain might have been affected. So it's hard to kind of say for sure, how concerned should you be. So I would suggest, depending on if it really was a serious one, I think just getting more intense evaluation would be what I would suggest. But it's hard to know for sure, whether that's going to really, lead to a dementia or not. There's other types. You may have heard of CTE, is what a lot of the NFL football players have been diagnosed with after they've passed away. That's another type of dementia. And what they're thinking there is that a lot of times is maybe not one big head injury, but just in football, have a lot of tackles and kind of a lot of smaller collisions add up over time. So it's hard to really pinpoint for sure, oh, this head injury means X% chance of dementia.
Both motorcycles.
Okay. Yeah, there's a separate topic, but I teach an ethics class, and Michigan is one of the states that has repealed its motorcycle helmet law. So an interesting debate over whether states should be allowed to require that or not. Yeah, okay, sure. Yeah.
alcoholism come under head injury?
Yeah, I wasn't thinking about alcoholism under head injury per se, but alcoholism, I'm glad you brought it up because that can be another risk factor for dementia in general. Because as you may have heard about it, heavy drinking is certainly not good for our cognition and can lead to problems down the line. So I think alcoholism could be another risk factor for dementia writ large. I guess it could lead to a head injury if you're so inebriated you stumble and hit your head. Yes, ma'am. Yeah, the question is, once you reach 85, are you kind of out of the woods? Unfortunately, that's not the case. I think people still, age continues to be a risk factor even after age 85. So, yeah.
Are the age factors dropping though? Are there younger folks with Alzheimer's?
Yeah, so the question is, are there younger people developing Alzheimer's? And the answer is yes. And as I'll talk about, sometimes genetics is a real important component of that. So people can get dementia before later life. It is still relatively rare, though, overall. The vast majority of cases are definitely 65 and above still. The back corner there.
The higher level of education, I have a question.
Yeah.
Does that mean we should all go out and get our master's or Ph.D. or why is that playing such a particular factor?
Yeah, it's a great question. What's behind this higher level of education? Yeah, I guess the short answer is I don't think you should rush out and get a degree unless you want to get a master's of public health at University of Michigan, where I'd be happy to accept your tuition dollars. But no, I think the thought there is something called cognitive reserve theory. The idea is that people who are in maybe more intellectually stimulating environments tend to develop what they call cognitive reserve. And what this refers to is maybe that there's more kind of complex networks that develop in the brain so that if something does go wrong, like in Alzheimer's, I mentioned those plaques that start to form. The idea is that people with higher levels of education can maybe compensate for that better because their neural networks in the brain are more kind of fully and richly developed. And so that if there is a brain injury, then the effects might not be as great. That's the theory, at least, I think, behind that finding. Yes, ma'am. Yes. Yes. Yes, correct. Because different types of the brain or different parts of the brain are associated with different types of neural functioning. Where there's like the occipital lobe in the back is really involved with vision, for example. Whereas like in Alzheimer's, there's a part of the brain called the hippocampus that's really highly involved in memory. These aren't necessarily like a one-to-one ratio, but they different parts of the brain, I think, do different things. And so I think that's the idea about why location would matter.
My three injuries were at different areas of my brain.
Okay. Well, yeah, I can't say more than about what but you seem, it's great that you're here today. So, yeah, that's a good point. So I think, and we'll talk about this, it's hard for me to give like people individual risk assessments in a general sense here. That's what I'm trying to do, but I do think folks can monitor and keep on top of things. And so, one way we do it at our center is we have a research study where we follow people on an annual basis, and we give them a lot of memory and thinking tests. And so I think a lot of participants, and we call it our UMMAP study, the reason they like that is they can track from year to year how they're doing. And I think that's something that we recommend if you are concerned, is to get what we call a baseline sense of how is your cognitive functioning through these kinds of tests. And then you can each year when you undergo the same tests, we can kind of compare how are you doing this year compared to last, if that makes sense.
Is all memory loss, should we be concerned about Alzheimer's? I mean, as I get older, getting, I went to a room or leaving my keys.
Yeah, no, I think, well, first of all, not all memory loss equals Alzheimer's for sure. As we do age, we do find that, you know, minor issues come up more frequently than they used to, whether it's, you know, you forget somebody's name, or if you're like me, you forget where you parked all the time. And those, there's certainly changes that are what we call normal aging, where are these minor issues occur, and they don't necessarily mean, oh, I'm heading down the road to Alzheimer's. If they start to happen more frequently, if they're more severe, and if they really start to interfere with your functioning, then that's maybe a sign that maybe you should try to get that checked out. Because, you know, for example, it's one thing to kind of get lost somewhere while you're driving, but if you're getting lost going to the grocery store you've gone to for 25 years, that's kind of more of a warning sign than just the act of, you know, getting briefly lost somewhere, if that makes sense. Yes, ma'am.
You spoke about alcohol drinking or excessive. What is excessive?
Yeah, it's a good question. I think it kind of depends on who you talk to. I think off the top of my head, I can't quite recall like the national guidelines, but I think the idea is that probably more than, you know, 1 or 2 drinks a day would be considered concerning, particularly as people age too. The effects of alcohol physically become more pronounced as well. All right, well, great question. So thanks for posing these. So I mentioned these risk and protective factors, and obviously there's a lot out there, but let's talk about genetics, because that's what I said we'd be focusing on. Before I talk about genetic testing for Alzheimer's, what I wanted to do was talk about genetic testing overall, because there's all different ways to do genetic testing these days and for a lot of different purposes. And usually what's interesting is now we can get DNA from very easily. Like you may have, I don't know if some of you have done 23andMe, this direct-to-consumer genetic testing service. All you have to do is spit in a tube, send it in, and then they give you all kinds of information about yourself. So it's easy to do genetic testing with just a saliva sample or blood sample. And it's done in the medical system for a variety of purposes. So sometimes it's for what we call either predictive or susceptibility testing. And so what that means, it's genetic testing to try to give you a better sense of what is your risk for a disease that you're concerned about. And the difference between predictive and susceptibility is predictive testing is if you have this genetic variant that's a concern, it means you're almost surely going to get the disease that you're being tested for. So Huntington's disease, you may have heard of, that's another neurological condition where if you have a certain genetic mutation, it means you're pretty much guaranteed to get Huntington's, you know, usually by your 40s or 50s. And those kinds of conditions run in families. So that's predictive testing. Susceptibility testing, you're still trying to predict risk of a disease, but the positive test is really more just giving you, well, you have higher risk. It's not a guarantee that you're going to get the disease, if that makes sense. So they're both, predictive and susceptibility testing are both about giving you a sense of what's my chance of getting this disease. The predictive testing is much more kind of a surefire result than susceptibility testing. Sometimes we do diagnostic testing. So there might be, like, this happens in pediatrics a lot, where let's say there's a child has like profound developmental delay, they're trying to figure out what's going on. A lot of times genetics might be the cause of that. And so this diagnostic testing would be, you know, the symptoms are already present and we're just trying to figure out what's going on. And so genetic testing might be helpful in that context. Another type of testing is what's called pharmacogenomic testing. So this is really genetic testing to help you decide with your physician, should you be prescribed a particular medication? Because genetic testing might be give us a sense of, are you likely to respond to this drug, or are you likely to have side effects from it. And so that kind of testing is done in the context of helping to determine should a prescription be made for a given medication. There's even genetic testing. I asked my students, have you ever undergone genetic testing? And a lot of them say no. And I'm like, well, that's not true, because almost all people, if you've been born in the United States from 1965 on, have gotten newborn screening. This is a genetic test that's done in the first few days of life for a variety of rare genetic conditions that can be treated. And so newborn screening is kind of a population-based genetic testing program. You had a hand up earlier? Yeah, I think we can make that possible. So that's newborn screening. Another type of genetic testing that's becoming more commonplace is what they call whole genome sequencing. So this refers to the fact that we can now, again, from just one drop, just one blood sample, test like your entire genome, look across all your genes, across all 23 chromosomes. And so it's not done a lot yet in medical practice, but it's kind of amazing how far we've come. So it used to be around the early 2000s, it would probably cost like $100 million to do a whole genome sequence. And right now it costs probably under $1,000 to do that same test. But a lot of times it's kind of a mixed bag here, because whole genome sequencing can kind of be like drinking from the fire hose. You're getting so much information, it's kind of overwhelming for the clinician. So sometimes I think they often prefer to do more targeted testing, but it is now becoming available. And then finally, I just wanted to, for all you Jerry Springer fans or CSI fans out there, you probably are aware that there's genetic testing for non-medical reasons as well, like determine paternity or for forensic purposes. Or I mentioned 23andMe earlier, they do genetic ancestry testing for people who are interested in kind of figuring out, where did their ancestors come from. So the ones in bold here that you can see are what I'm going to be talking about in the context of Alzheimer's disease, because those are the types of tests that we consider, at least in Alzheimer's. But before I move to that, any questions on this broad overview of genetic testing types? All right, well, since I mentioned predictive testing, I mentioned it for Huntington's disease. Well, it turns out there is predictive testing for certain types of Alzheimer's disease as well. And if you've ever seen the movie Still Alice, where Julianne Moore won an Oscar for Best Actress, she portrays a woman who is dealing with familial Alzheimer's. So she has one of these rare genetic mutations that causes Alzheimer's disease. And so, again, I mentioned the 1990s is a big time in genetic research. Since the 1990s, we've been aware of there are 3 different genes out there where if you have a certain mutation in one of those genes, you're almost inevitably going to get Alzheimer's. They're called the APP and presenilin genes. Fortunately, they're very rare. So probably just like 1 to 2% of all Alzheimer's cases overall. We have 6 million people right now that's estimated to have Alzheimer's in the United States. So relatively few of those are accounted for by these rare genetic mutations. But in the families that are dealing with that, you can imagine that's a major deal. And the question earlier about age is important here, because people who have one of these rare genetic mutations, they can develop Alzheimer's even in their 30s or 40s. So much earlier onset for this type of dementia. Whoa, can we maybe turn those lights down, or can you still see fine, or should we turn them down? Okay. I'll just keep plowing through here. And because this is what we call an autosomal dominant condition, all right, perfect. So in this situation, so Julianne Moore in the film, if you ever saw it, her adult daughters had to decide, do I want to know, once they identified this, she had a genetic mutation. The question was, well, do her adult children want to learn whether they have it? Because they each would have a 50-50 chance of having it passed down to them. So it raises some really interesting and challenging dilemmas for families to try to figure out, would they want to know, and when would they want to know? And so for these kinds of situations, we do have genetic testing and genetic counseling available in specialty clinics where people can undergo, but you probably wouldn't be referred to one of those unless you really had a family history that was suggestive of this familial Alzheimer's, where you would have maybe at least 2 relatives who had that early onset. Then you might suspect, well, maybe we should try to check out whether it's one of these rare mutations.
Then I need to go to college.
Yeah.
That's it. And
Then you need to go to college to reduce your risk.
Get a doctorate.
Good point. Any questions on this predictive testing for familial Alzheimer's?
I can have a general question.
Yeah.
I have a mother-in-law who's very difficult. Not one diagnosed that she's losing it. She hadn't seen her PCP. They retired 2 years ago. The daughter was supposed to take her and never did. She's diabetic, uncontrolled. And she finally did see the PCP, hadn't seen her. And they started to do some cognitive testing on her. They asked her 2 questions. And first one was, what do you do if your stomach catches up? She's like, oh, call 911. How many grandkids you got? 3. And the PCP stopped and advised my husband if she went any further and she was found to be incompetent, she would have to. How I talked to the attorney, and the attorney said, as a primary care physician, she doesn't have the qualifications to diagnose her with any type of dementia. She needs to see a specialist.
I think that would be an ideal situation, is because without getting too far off topic here, I think you're bringing up the important point of how is a diagnosis of Alzheimer's made. Ideally, you have a pretty in-depth assessment. So not just the kind of memory testing where you're asking questions, but you would have a neurological exam. Ideally, you would have maybe some even brain imaging to see what's going on. The challenge there is it can be really hard to find specialists, and they have big waiting lists. So it's easier said than done. But yeah, I would encourage folks who are interested, either for themselves or a loved one, if they can try to pursue a diagnosis made by a specialist, that would be great. We actually have in our back, we have some brochures. We have a cognitive disorders clinic at the University of Michigan where we have neurologists who are expert. But again, you can't get an immediate appointment. So I think that's the challenge for people, is they're trying to wait. But I'm glad you brought up this point about the importance of getting an informed diagnosis. So I mentioned in this familial Alzheimer's, you would undergo what's called genetic counseling. I don't know if people have ever heard of this field, but it really refers to genetic counselors are master's levels clinicians who know a lot about medical genetics, and they're also experts in providing education and support. So they're great folks to see if you're thinking about doing a genetic test, because they can walk you through, before you decide to even get it. I think it's important to take a step back and figure out, well, what are the pros and cons of learning this information? Because unlike other types of medical tests, genetic tests have implications not just for you, but possibly for your family members as well, because their level of risk might be changed by what you learn. And so I think genetic counseling can be a great tool for people to think through the implications of the test. And then genetic counselors then can also be helpful in explaining, well, what do the results mean and what should I do for my next steps? But again, like we're talking about with specialty neurology care, genetic counselors are relatively few in number. So there can be challenges finding them. but they are a great resource, not just for genetic testing for Alzheimer's, but for genetic testing for all kinds of medical conditions. All right, so let's shift from predictive testing to talk about susceptibility testing. Remember I said susceptibility testing means the genetic test result means you have a higher chance of a disease, but it's not, a definite. And so that's the case with what we call Apoe testing. I don't know if people have ever heard of this gene called Apoe. It stands for apolipoprotein E, and it's a gene that's found on chromosome 19. And again, like the familial AD genes, we've known for decades that it's linked to risk of Alzheimer's. So we all have an Apoe genotype, and there's 3 common alleles, which are called E2, E3, and E4. And so we each inherit one Apoe allele from each of our parents. So we all have an Apoe genotype that's made up of these 2 alleles. And so E4, if you have this E4 allele, that's the Alzheimer's linked risk factor. So, but on the other hand, unlike the rare mutations I was talking about with Julianne Moore, E4 is neither necessary nor sufficient to cause Alzheimer's. You could get Alzheimer's and not have an ApoE4 genotype. On the other hand, you could have an ApoE4 genotype and never go on to get it. But it does significantly raise your risk. And to make things even more confusing, Apoe is also linked to risk of other health conditions. So for example, E4 is a modest risk factor for heart disease as well, not just Alzheimer's. Sometimes a picture is worth 1,000 words. So just to kind of show how this inheritance works, so let's say you had a mother who had an E2, E3 genotype, and a father with an E3, E4 genotype. Their children could have a range of Apoe genotypes. And so you can see, it's kind of the luck of the draw. And so maybe some of their kids would inherit that E4 risk allele from the father, but some might not. And so I think this is how inheritance of the Apoe genotype works. Yeah.
This is something different than dominant recessive genes, correct?
Yeah. So it's not like your Mendel peapod you may have learned about in biology class. So because where the familial ID I just talked about, that is an autosomal dominant condition because the mutation almost inevitably causes this. This is really just about inheriting a potential susceptibility gene, which in this case is the E4 allele. And just to give you a sense, what makes Apoe testing interesting to me is that we have a lot of people out there who have at least one of these E4 alleles. So you can see in the general population, you can see E4 is represented in about over 25% of people. So probably several of us in this room have at least one E4. And if you have 2 copies of E4, like let's say you inherited one from each parent, that's relatively rare in the general population. Only 2% have that genotype, but it makes your risk even higher than having just one E4. So, and in terms of what does this mean in terms of numbers? So remember I said the general population risk was about 10 to 15%. If you have 1 copy of E4, it about doubles your risk. And if you have 2 copies, your risk might even be greater than 50%. So on one hand, I think those numbers show that E4 is a really important risk factor. On the other hand, you can see even if you have the worst case scenario of 2 copies of E4, there's still a lot of people who never get Alzheimer's, even though they have that concerning Apoe genotype. So any questions on, I know this can get kind of complicated when we're talking about genotypes and risk percentages and everything. Well, maybe I'll just pause here. How many of you, knowing what I've told you, how many of you would actually be interested in learning your own Apoe genotype? So several of you would. How many of you would not be interested? How many of you are kind of on the fence? Yeah, if you're my wife, you're like, why would you? She's like, I don't want to know anything unless I absolutely have to do something about it because it's just going to be like this black cloud hanging over my head. Whereas I'm kind of like, I love information. I feel like information to me is is even if I don't necessarily immediately act on it, I just like to know things that are relevant to my health. So it kind of depends on your, and there really is no right answer there. It's not like Apoe testing is definitively recommended. In fact, it's not, given its limitations. But it's interesting that a lot of people, as in this room, are interested in this.
There's really nothing you can do about it, even if you found out, get a double 4, right? Except maybe get a Ph.D.
I think I wouldn't be that, I don't think it's that bleak. And I'll talk about, because we've done research, like what do people actually do? So I'll get into that, like the reaction. So, but there are some ways, I think the short answer is people feel like they can do health behaviors, and it doesn't have to require get a PhD. There are other health behaviors that might lower your risk. And a lot of people feel like it's maybe helpful for advanced planning as well. But yeah, Apoe genotyping, it's not recommended in clinical practice because part of what you're saying, it's not what we call actionable medically. It's not like, oh, if you have E4, we're going to put you on this medication, or and also there's concerns about potential harm. So some people are worried, are people going to become clinically depressed if they learn they're at high risk, or others are concerned about stigma, and I'll talk about what's called genetic discrimination. Could you be discriminated against by your insurer, or something like that? But there's a lot of people who are interested in this information as well. And it just so happens, I'm not endorsing this, but I think it's important to note that there are companies out there who do what we call direct-to-consumer genetic testing. So that is, they bypass the whole medical system. I mentioned, you send in a saliva sample, and then they give you back all kinds of results. And so part of what 23andMe does, they give all kinds of information for ancestry and other health-related conditions, but Apoe testing is one of the tests they do as part of their service.
I have a question.
Yeah.
How well can you trust their testing? Because they know with the ancestral testing, it seems like it changes from time to time. I mean, I have a cousin who's half Italian who was tested, and they said she was only 12% Italian. And then 6 months or a year later, I asked her about it, and she says, "Oh, they kind of changed the statistics now. Now they're saying I'm actually half Italian."
Yeah, that's a great point. So you're saying, well, how reliable is this information? Right. So with the ancestry, I think it is much more of an imperfect science, and there is this kind of moving target nature of the information. I do think, however, with Apoe testing, they're going to be very accurate in calling your Apoe genotype. It's not that hard to determine someone's Apoe genotype from a genetic test. So I think they would probably be very accurate in letting you know what your Apoe genotype is. But the question is, that's still going to be ambiguous, though, in terms of what is your risk for the disease. It's not going to give you a precise yes or no answer whether you're going to get Alzheimer's. But it would, I think, tell you your Apoe genotype. And I think you probably could trust that information, if that makes sense. Yes?
Well, can it be testing? Does it have to be disclosed to your insurance or your employer?
That's a great point. Well, I think a lot of reason why people like the direct-to-consumer is they control the information. 23andMe is not going to share it with any kind of medical provider. You can bring your test report if you want, but you're basically in control of your information. And so I think a lot of people, have these concerns. And so sometimes people actually, if they're worried about insurance, they will actually ask for genetic test results to not be in their medical record. But then that's a tough dilemma, because I think providers don't like to, withhold information that might be important for someone's medical record. So that's where direct-to-consumer has some appeal if people are really wary of who might use it against them. I think the good news is, I don't think there's a lot of evidence that genetic discrimination is commonplace. I don't think it happens a lot, but it's not to say it couldn't happen. And I'll talk a little bit more in just a minute about one of my slides really focuses on genetic discrimination. So Apoe Disclosure, like I mentioned earlier, our group has done a lot of research in this area where we have taken folks who are interested in learning their Apoe genotype, We provided them the testing. We've had a genetic counselor give them the results, and then we followed them for up to a year to see, how do they react to learning the information. And the good news is, even though it's complicated, our participants have generally understood the main take-home messages from Apoe testing. They get that E4 raises their risk. They also get that it doesn't mean they're definitely going to get Alzheimer's. And then fortunately, we found that there was a lot of concern. Oh, if you tell people bad news, they're going to become clinically depressed or anxious. But we found that in general, that was not the case. And if it did happen, it usually was pretty transient. So people kind of went back to their baseline level pretty soon. They might have an initial distress in the maybe week or two after learning their results, but they pretty quickly rebounded. So some of these harms that were speculated, we did not necessarily see in our studies. We also found, I mentioned this idea of genetic counselors being rare in number. So we've done studies where we've tried to say, well, do we really need to have kind of 2 full sessions of an hour long each? That's kind of the traditional genetic counseling model, but we've been able to kind of have a more streamlined approach to do it briefer. And also, it doesn't always, as we found out in COVID, not everything requires an in-person visit. So we've been able to show that a telephone disclosure protocol was about as effective as the in-person. And then what do people do? So people engage in a variety of health-related behaviors. I mentioned some of the diet and exercise before, and a lot of people are thinking about planning for the future. And long-term care insurance is one area where we saw a lot of people making changes. So I'll talk a little bit about that. One change that we also saw that wasn't totally concerning on the face of it, but brought up this broader point was this idea of taking nutraceuticals. So a lot of folks, maybe you guys have heard, you hear about, oh, vitamin C or vitamin E or ginkgo biloba, these things might be good for your brain. And so unfortunately, the science is not highly convincing for a lot of these products. And if you go to a health food store, you're seeing more and more these products that are like focus factor, nutrition for the brain, or senior moment brain health supplements. So I always like to point out that I would be wary about these being able to truly deliver in a major way for your brain. I don't think the science really supports some of the claims that I think these products are making. So I think that's one caution. I have a general statement that if it sounds too good to be true, it usually is with some of these kinds of products. But you brought up the issue of insurance. So we did find that some folks were saying that they made changes to their long-term care insurance, because that would make sense. Long-term care insurance might help provide care for if someone develops Alzheimer's or another dementia. And so it's important for people to know that there are some legal protections out there against genetic discrimination. So back in 2008, there was a federal law called GINA that was passed under the Bush administration, stands for Genetic Information Non-Discrimination Act. And so it prohibits the use of genetic information by health insurers or employers. So your question earlier was like, about could insurance get access to information? It would actually be illegal for an employer to use genetic information against you. Like, let's say, oh, we don't want to hire this person because we think they're at high risk for a cancer that might jack up our healthcare costs. It would be illegal for them to make any kind of employment decisions based on your genetic information. It's also illegal for health insurers to do that. They can't, raise your premium just because you're at genetic risk for Alzheimer's, for example. So I think that's good news that we do now have these legal protections against misuse of personal genetic information. But I think it's also important to note GINA does not cover it covers health insurance, but it does not cover long-term care, disability, or life insurance. And so those are some gaps in that legal protection that might be important to be aware of if you're thinking about genetic testing and to inform some of these kinds of decisions. I'm not saying that these industries are actively discriminating against people. It's just that there's not that legal protection like we have for some of the other domains.
I have a question. question though, why would an insurance company want to take on somebody that they know would be a higher risk? Do you understand what I'm saying?
Yeah, so why would they do that? I mean, luckily,
This would be just a business model anyway, because insurance companies are kind of the pool of large numbers.
yeah.
More people you get under your insurance umbrella, the better.
Yeah. And I think because most genetic conditions are still pretty rare, I think for insurance companies, if they have a big enough customer base, they're not going to be, put out of business by a few people here and there who have high genetic risk for a given condition.
What I'm saying.
They may not like it, but it's at least they would know with this, since it's illegal, that hopefully none of their competitors are getting an advantage either. So I think the playing field would hopefully be equal from their perspective, given these legal protections. There's a lot of genetic testing that's done in research studies as well. And maybe some of you, if you're part of our UMMAP study at U of M, or you participated in other projects, it's routinely collected in a lot of Alzheimer's studies, this genetic information, because Apoe, for example, is something that researchers like to know about. And I think we're seeing a lot of interesting genetic research in this area. Typically, genetic results on the research side of things are not given back to people. So usually in research, the idea is we're trying to learn something, for the general public, not necessarily providing clinical care to individuals. But I think what's starting to happen is more and more participants, though, are interested in knowing, hey, how did I do on that memory test that you put me through? And more people are starting to say, hey, what was my genetic test result? And so at Michigan and at other sites, we're trying to move towards a model where we give back some of that individual research information more. So there's also neuroimaging. So there's a lot of different types of information that might be of interest, that I think we're seeing a trend towards trying to disclose that to people if they are interested. We're not quite ready on the Apoe front, at least at Michigan. We don't yet have a protocol for disclosing that particular piece of information, but we do have feedback for a lot of other types of information that we collect in our studies, whether it's the diagnosis someone has, or how they fared on memory testing, what their imaging results said. So it's an interesting kind of broader debate in the field, like what should people get back if they're in a research study. And then what's happening now is, you may have heard of these drug trials that are being done in Alzheimer's. More and more drug trials are trying to actually intervene earlier and earlier in the disease. So this slide is what we call the Alzheimer's continuum. And there's now a stage called preclinical Alzheimer's. And what it means is, this is someone who has no symptoms whatsoever. Their memory and thinking is totally intact, but we can now maybe tell from either genetics or biomarkers that they have some initial warning signs of the disease. So I mentioned earlier, amyloid plaques and tau tangles. Those are the two cardinal features of Alzheimer's. We can now, with neuroimaging, detect whether those plaques and tangles are starting to develop in the brain. And sometimes it starts to happen, 10 to 15 years before any symptoms. And so that's become an exciting development, because the idea is, hey, let's try to intervene with medications before people have any symptoms whatsoever, thinking we'll have a better chance that way than if we wait till someone already has, full-fledged dementia. Does that make sense? Yeah.
As far as the medications, at what percent actually seem helpful?
Yeah, well, I think right now we just have medications that are diagnosed for kind of people on this side of the spectrum. And sometimes they can be useful in terms of relieving symptoms. The most commonly prescribed one is called Aricept, that you may have heard of. There's Namenda. So there are some FDA-approved medications that can be useful in some cases. However, they're not going to reverse the symptoms. They're not going to cure the disease, and their effects usually don't last for a super long time. And so that's why I think we're seeing a lot of effort to try to improve on what we have in terms of prescription medications. And that's where these prevention trials are trying to say, well, they're envisioning a future where we would actually use some of these genetic and biomarker tests to say, hey, you're at high risk for Alzheimer's. Let's get you started now on something, kind of like we do with statins, in heart disease. You try to do it in a way that's kind of a preventive way as opposed to reacting later on down the line. Yes, ma'am.
So that preclinical, that be the testing, and then if you're negative preclinical, you can start on medication.
No, it'd only be if you actually have these signs, if you're positive for preclinical. So if you had, like, let's say they did a PET scan and they saw amyloid plaques were starting to develop in your brain, you might be fine. You might have no symptoms cognitively, but if you had that evidence in your brain of plaques and tangles, that's what might make you eligible for one of these treatments. Does that make sense?
When would you start taking the Aricept?
Well, right now, Aricept is only prescribed for people who already have dementia.
Oh.
Yeah.
What about the MCI?
Well, sometimes it's kind of that's more of a judgment call for the clinician and the person. So some people with MCI are being prescribed Aricept, but I think it's only formally approved by the FDA for dementia. But I think the field is, since we've had a struggle to find great new treatments, the field is trying to say, let's move things earlier and earlier in the disease process. And so we have a lot of these prevention trials out there that you may have heard of. Some of them are using genetic testing to identify who's eligible for the trial. So you may have heard there's one, and again, a lot of this is that familial Alzheimer's, the rare mutations I mentioned earlier. But we do have some studies like these generation studies where they're taking people who have that E4 genotype and enrolling them in prevention trials. And so the idea is they're using these folks who are at high risk to see, can these medications be beneficial? Unfortunately, as of yet, we don't have any great results from that. And just back a couple months ago, we saw one of these trials actually. It was a really interesting trial because they enrolled folks from a part of Colombia, South America, who were had one of these rare mutations, and so they knew that the person was inevitably going to get the disease, and so they put those folks. They either randomized them to get the experimental medication or to a placebo control group, and they followed them for several years. And so they just are now, in fact, next week. We have our big international Alzheimer's meeting in San Diego. You might hear some news reports about this, but the findings, unfortunately, were that the treatment group versus the control group, there were no significant differences. So we're not seeing, as of yet, any proven approaches, at least medication-wise, to prevention of Alzheimer's. And you may have heard there's a lot of controversy over what's called this amyloid hypothesis, this idea, because a lot of these medications are really trying to target those amyloid plaques in the brain. And we put a lot of effort into that particular approach. And we continue to see these clinical trials don't necessarily seem to be working with these anti-amyloid drugs. And that's a lot, kind of complicated topic, but any questions on either clinical trials for Alzheimer's and the use of genetics to try to identify high-risk groups to participate? Yeah.
If you are in the clinical trials or research and you get genetic testing, does that negate your participation in the research?
No, in fact, it's genetic testing might be used to say, are you even eligible for this trial in the first place? Because in those trials, they want people they know are at elevated risk. And so the way they figure that out is, in some trials, is to do genetic testing. So if you have that Apoe genotype that I said confers higher risk, then they might say, all right, given your Apoe genotype, you can now take part in this trial. Or in some of the trials, it's been that rare, they've found these families where they have the rare mutation, and they're trying to appeal to those family members to take part in the trial. So I mentioned pharmacogenetic testing earlier. So let me just say a little bit about this. This is not commonly done yet in Alzheimer's, but it's kind of something that might happen more in the future. And remember, I said that pharmacogenetic testing was genetic testing that's trying to inform a decision about whether you should go on a particular medication, because we know that people's genetic differences might affect how they metabolize different drugs. And this is done in a lot of other medications in medicine, because sometimes the genetic test can identify, oh, you're likely to be a poor responder to this medication. You're likely to not, gain the benefit. Or sometimes the genetic test might identify, hey, you might be at high risk for these really concerning side effects, so you should not take this at all, for sure. There's some rare genetic variants that, maybe there's one that I think is like a fatal skin reaction people can have to a particular medication, and it's rare, but it's seen in people who have a certain genetic variant. So in those kinds of cases, the FDA has said, before you can even prescribe this drug, you have to get this genetic test to see, are you in that rare group of people who might have a really bad reaction. So I think in the terms of Alzheimer's, where things might be going is, and I mentioned Apoe testing before, we're starting to see it might be potentially relevant for prescription of Alzheimer's medications. So just this past year, we had a new drug approved for treatment of Alzheimer's called Agitcanamad. Some of you may have heard. It's created a lot of controversy, but it is a new medication that's available for treatment of Alzheimer's. So it was the first time, I think, in almost 20 years where we had seen the FDA approve a new medication. The problem is it doesn't have a great risk-benefit ratio. So it's not like a slam dunk, you should definitely put all patients on this. It's more kind of murky. But Apoe testing is relevant because with this medication, it can help determine risk of a certain side effect that we've seen with Agitcanamab called ARIA. It doesn't refer to the opera term ARIA. It refers to amyloid-related imaging abnormalities. And so what does that really mean? It kind of refers to some usually mild swelling in the brain or microbleeds. They're typically benign. They don't result in any symptoms, but sometimes they can result in symptoms like headache or nausea. And in rare cases, they can even be cause for hospitalization. So that's one side effect of Agitcanamab that I think patients and families should be aware about before they decide to go on it. And what it just turns out that Apoe testing is important here, because remember, I said not only are E4 carriers at higher risk for Alzheimer's in general, they also seem to be at higher risk for this ARIA side effect. So the new guidelines for prescription of Agitcanamab suggest that a patient gets Apoe testing before they go on the medication. Because for a couple of reasons. One is if they get an A4 result, maybe that tips them to say, well, you know what, I don't really want to try this medication because I'm concerned about the risk of side effects. Or maybe they decide I do want to go on it, but if they know they're an E4 carrier, they and their physician might know, well, let's monitor more closely for some of these side effects. Maybe they have more frequent check-ins or assessments. So that's where Apoe testing might start to become relevant, not to predict who's at risk, but to predict how should we prescribe medications and what's the pros and cons of doing that. Does that make sense to folks? Any questions about Apoe testing in the context of prescribing Agitcanamab? So, I mean, a big picture question you might be having here, well, what should I do at the end of all of this? A lot of information here, a lot of it's kind of in this gray area. And I think when people are saying, should I get genetic testing, they're often really ultimately interested in what can I do to lower my chances of getting the disease. And so we We talked about, Mr. Taylor, you mentioned, oh, is there nothing we can do? I wouldn't go so far to say there's nothing you can do to lower risk, and we'll get into that in a second. But I also wanted, if you are interested in Apoe testing, there is this website out there called genetestornot.org that's specifically for that Apoe test that I mentioned earlier. And so it's kind of a neat little website where it's called what we call a decision aid. It'll kind of walk you through, it'll give you information about the Apoe test. It'll ask you some questions about, why are you pursuing this? What are your reasons? And it can give you some guidance that might help you make a more informed choice about whether the Apoe test is right for you. But if you're just interested in lowering your risk of Alzheimer's, there actually is a lot that might potentially be useful in terms of behaviors. And so the Alzheimer's Association has put out this 10 ways to love your brain campaign. And so you can see, if you go to their website, it has more information, but it deals with some of those risk and protective factors we were talking about earlier. So, the head injury is like, heads up, like try to guard against head injury. Maybe make sure you wear a helmet while you're biking, for example. We talked about the link with heart health. This is not smoking. This is mental engagement, physical activity, paying attention to diet, paying attention to your sleep, taking care of your mental health, being social, trying new things cognitively, whether it's crossword puzzles or other kinds of things that might stretch your cognitive abilities. So there's none of these in and of themselves are guaranteed, to prevent Alzheimer's for sure, but all of them have been associated with at least slightly lower risk. And so the more of these we do, I think, the better. That doesn't mean, again, you could do all these things and still develop Alzheimer's. I don't want to turn into a situation where we blame people, because, oh, if you'd only done the right things. That's not the case at all. On the other hand, I think there are things we can at least do to lower our chances. And the good news is a lot of these things, as I mentioned earlier, are just things that are good for us in other ways as well. They're good for our mood, they're good for our physical health in other ways, and they're good for our quality of life. So these are, if you're interested, you might check out the Alzheimer's Association's website here. Again, it's called 10 Ways to Love Your Brain is their website. And then interestingly, we just saw a report that kind of, I think, reflects a lot of the Alzheimer's Association recommendations, but adds a few others in here. We haven't talked about, like, they actually talked about air pollution as being relevant. And we're talking about dementia overall, not just Alzheimer's, but they bring attention to hearing impairment as an important thing. A lot of people could make use of hearing aids, but aren't using them. And so that could be something to keep in mind too. And I think the Lancet report was basically saying a lot of these behaviors can do two things. Some of them might actually directly address some of the brain issues I was talking about with amyloid and tau, but some of them might not directly affect the brain in terms of the pathology, but they may actually enhance that cognitive reserve I was talking about earlier, so that if you do have some of this damage, you can be better able to compensate against it. So these are just some recommendations that are out there, and I put them out there just to kind of, again, as a ray of hope that there might be things we can do both individually and as a community to lower chances of dementia. So, yeah, I think that's, I'm not sure if that would be encompassed here or not, but that's a good point. I actually don't know off the top of my head. I think here, what they're talking about is usually people not being able to, to hear it all, to the point where they would need, hearing aids. And I think I was amazed to see the statistics, just how common that is. And not only how common it is among older adults, but how many people who could benefit from hearing aids are not using them for one reason or the other. Maybe it's access, or maybe if it's like my dad, it's like various stubbornness around using it. But I think it's important, not just in its own right. I think people, if they hear better, can better engaged, but I think there is some evidence it might relate to cognitive impairment down the line. All right, well, I kind of yammered on a lot here, but just to kind of bring it back, I hope I've helped you see that there are several different types of genetic testing for Alzheimer's. None of them are recommended as what we call standard of care. There's not, any genetic test that we say you definitely need to be getting. On the other hand, there are some out there, and some might become more useful down the line. I think if you are thinking about genetic testing, I think we talked about, really getting informed about what are the benefits and risks. What are the implications, not just for you, but also your family members, and ideally getting some guidance from a knowledgeable professional. And I do think, though, we will see this become more commonplace, whether it's in that realm of pharmacogenetic testing I mentioned earlier, or even like Apoe testing for risk of Alzheimer's. I think as we get prevention strategies on board that really have high efficacy, I think we'll want to know who's at high risk, because there will be more medically that we can recommend. So I'll pause there to see if I know we had some questions along the way, but are there other questions that folks have at this point? Yes.
So the testing, if you get the genetic testing, it's not 100% sure that you're going to get it.
Correct. For the Apoe, that familial testing, that would be close to 100%, but that's that's pretty rare, though, because again, remember I said it's like 1 to 2% of all cases, and it would only be ordered if you have like a family history where you have multiple people with early onset Alzheimer's in your family. But in general, the type of testing that's relevant to most of us, Apoe testing, is not a definitive yes or no answer. Yeah. Yes, ma'am.
The concern I really have with my is the lack of sleep. I've got insomnia.
Yeah.
And I do have on medication.
Yeah. Yeah, I would, there is, I don't know if you've ever heard of this term of sleep hygiene. There are some things behaviorally we can do to, again, it may not be a foolproof method, but there's a lot of little tips that sometimes I didn't realize how important, for example, like the temperature of your room is to enhancing sleep quality. Or if you're like me, you love caffeinated beverages. And so, needing to attend to like, well, when do you have that last caffeinated beverage, or like what are you doing at night? I'm sometimes watching these crazy Netflix series, and it's all stimulating, and it's right before bedtime. So I think you can kind of take a look at some of those kinds of behaviors and see, is there anything that can be improved? And there are medications, but I understand your reluctance given some of the side effects. Yeah. Yes.
And while cognitive doesn't necessarily have to advance, does it to advance into Alzheimer's?
Yeah, so mild cognitive impairment, or MCI, that refers to people who have cognitive impairment that's more than we would expect given their age. So more than just these like rare senior moments, but it's not to the point where their everyday functioning is impaired. So they can still pretty much carry on their everyday activities of living. It's just that their memory and other thinking is not quite what it used to be, and it's more extensive than we would expect given their age. A lot of people with MCI do go on to develop dementia, but a lot of people do not. A lot of people stay at that MCI stage for indefinitely. And I think it's also, that's where MCI as a term says nothing about what's the underlying cause. And so that's where I think getting a good assessment to try to figure out what is really causing the mild cognitive impairment. You could have mild cognitive impairment in a clinical depression, for example. And so if you treated that clinical depression, maybe the cognition improves. On the other hand, you could have mild cognitive impairment that is due to Alzheimer's disease, and that person does progress. So I think it's kind of this, in between phase where I think it is important to get a good medical assessment to try to figure out what's really driving it.
That
Apoe. Apoe, yeah. So Apoe testing might, if you were an E4 person, it might suggest that your chances of developing dementia are higher than average. Again, it wouldn't say for sure you're going to get Alzheimer's and other dementia, but it might be an important risk factor to know about.
This shall be the MCI advance or not.
Again, it would be more of just kind of a probability. It'd be like you have a higher chance. It wouldn't say you're definitely going to advance, but it's more likely than people without that E4 that you would go on to get it. So it's kind of true. Probability is really hard, I think, because I think people desire like a more clear-cut answer. And I think sometimes all we know about with some of these risk factors is, oh, you have an elevated, kind of like, you know, smoking and lung cancer, high cholesterol and heart disease, these things where we know it's better to not have them, but it's not for sure going to cause disease. Although smoking is pretty tightly, maybe that's a bad example. Yep.
And why would the testing, the Apoe testing, who would you go through other than the 23andMe or whatever?
Yeah, it would have to be through, you know, a physician, and they tend to be kind of wary because, again, it's not like it's going to change their care of you. So I think a lot of physicians are like, why open this box? But it's not to say it would be impossible. So it might be worth a discussion with your physician, but it tends to not be used for susceptibility testing right now in medical practice.
That would be a blood test.
You know, the 23andMe is just a saliva test, but I think in medical context, it probably would be more likely to be a blood test, but it could be, you know, multiple ways to test it.
So are you offering that test?
We are not offering that. We do collect Apoe information in some of our research studies, and we're, like I mentioned earlier, we're trying to move towards a place where if people are interested, we will give that information back to them. That's in the works. It's not happening right now with our research studies. And speaking of our research studies, let me just say, I think some of you are aware, some of you are already involved in our research, so we really thank you for your participation. But in the back, we have all kinds of materials that you can take that let you know about what's happening. We've got, I think, over 20 different studies that are recruiting now. So we've got a list of those in one of our handouts back there. We also just have a more general registry called the Mindset Registry, that if you want to sign up for it, it'll get you on like our list to be contacted with information, our newsletter. And so it's not a commitment to, you know, you definitely have to take part in a study, but it's a way of kind of getting into our system and being kept apprised of what we're doing. So just also, our website is listed here, alzheimers.med.umich.edu. Our point person for our research registry is Kate Hansen. Her email address is there. You can also just sign up. I think we have a sign up sheet for our registry. If you wanted to just sign up today, you could do that. So with that, I'll close. Thank you so much for your attention. I can stick around, you know, to answer questions one-on-one. I think we have some Panera lunch goodies in the back. Stephanie, any other things you wanted to mention before we go to lunch?
Put it on your evaluation form. You can turn it either to me or Annette or Sarah. And yes, please stick around, enjoy some lunch, and you can ask us any further questions if you need.
Thanks. You said this.